Welcome to Pulse&Pressors, where critical care gets crystal clear. Pancuronium is a long-acting aminosteroid neuromuscular blocker known for its duration, vagolytic effects, and reliance on renal elimination. It has no histamine release and is hemodynamically stable, but its long duration makes it unsuitable for critical illness. The drug creates prolonged paralysis and must be used with extreme caution outside the operating room. Pancuronium competitively antagonizes nicotinic acetylcholine receptors at the neuromuscular junction. By preventing acetylcholine binding, the muscle membrane cannot depolarize, producing sustained flaccid paralysis. This mechanism avoids potassium shifts or fasciculations, but produces a long recovery curve. The drug is metabolized in the liver and eliminated primarily by the kidneys. Its active metabolite, 3-OH pancuronium, retains significant pharmacologic potency and accumulates in renal or hepatic dysfunction. This leads to prolonged paralysis long after administration stops, especially in ICU patients. Pancuronium's ED95 of approximately 0.07 milligrams per kilogram indicates high potency. Its long duration makes it unlike other aminosteroids. Its onset is slower than rocuronium, making it less suitable for emergent airway control or rapid sequence induction. The onset of action is 2 to 3 minutes, with a duration ranging from 60 minutes to 2 hours. In sepsis, shock, renal injury, or multi-organ failure, its duration becomes dangerously prolonged. This makes pancuronium inappropriate for continuous infusions in the ICU. Pancuronium causes vagolysis by competitively blocking cardiac muscarinic acetylcholine receptors, preventing the vagus nerve from slowing the heart rate, often resulting in tachycardia. This can be useful in patients with bradycardia. However, in patients with ischemic heart disease, tachycardia may worsen myocardial oxygen demand. The drug produces no histamine release and very stable blood pressure. However, sympathetic stimulation can be problematic in cardiac disease. Its hemodynamic profile is predictable, but not universally beneficial. Dosing includes an intubation dose of 0.08 to 0.1 milligrams per kilogram and a maintenance bolus of 0.01 milligrams per kilogram. Continuous infusions are not recommended because of significant accumulation and metabolite potency. Renal dysfunction requires major dose considerations. The active metabolite, 3-OH pancuronium, accumulates in renal and hepatic dysfunction. Because this metabolite is highly potent, paralysis may be prolonged for hours or even days in critically ill patients. This characteristic defines why pancuronium is avoided in ICU sedation paralysis strategies. Pancuronium is well suited for long-duration surgical procedures where physiology is controlled and rapid recovery is not needed. Its mild tachycardic effect can support patients with baseline bradycardia. The drug should be avoided in renal failure, hepatic dysfunction, shock, or any situation requiring predictable recovery. ICU infusions dramatically prolong paralysis and create dangerous delays in awakening or spontaneous breathing. Aminoglycosides, magnesium, lithium, and calcium channel blockers potentiate blockade, while chronic anticonvulsants induce partial resistance. These interactions are important in surgical and critical care settings. In critical illness, pancuronium becomes unpredictable. Its metabolite accumulates, leading to prolonged paralysis and delayed return of respiratory drive. Residual blockade is common, making train of 4 monitoring essential for safety. Pancuronium can be reversed with neostigmine and glycopyrrolate. Sugamidex is particularly effective because pancuronium is an aminosteroid paralytic. After sugamidex, pancuronium should not be redosed because the reversal agent will bind and inactivate it. Pancuronium is reliable for long, stable cases in the operating room and in patients who may benefit from mild tachycardia. However, it is inappropriate for ICU infusions, sepsis, multi-organ failure, or when predictable recovery is essential. Pancuronium remains a dependable, long-acting paralytic for OR settings, but its metabolite accumulation, tachycardia, and prolonged duration make it a poor choice for critical illness. It should be used with precision, train of 4 monitoring, and careful patient selection. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.